our monthly breastfeeding webinar series. We're so glad that you're here. We'd like to say a big thank you to our sponsors, the Indiana Breastfeeding Coalition, the Indiana Perinatal Network, Michigan Department of Health and Human Services, MD Wise, Indiana WIC, and St. Vincent Health. My name is Margie Searle. I am the breastfeeding coordinator in Michigan, and we're so glad to be joining with our partners at Indiana in order to bring this webinar to you. So today we have Dr. Paula Schreck, who is going to present on why breastfeeding for pediatric offices, and we are so excited to have her able to join us today. And Dr. Schreck is a pediatrician and an IBCLC. She attended U of M Medical School, where she completed her residency, pediatric residency at UC San Diego. She's also the creator and medical director of the St. John Mother Nurture Network, a W.K. Kellogg Foundation-supported innovative and far-reaching breastfeeding initiative, and it spans her urban hospital and the surrounding community, and I can testify to that. She is just having some incredible effects here in Michigan. She's the medical director and co-creator of the Mother Nurture Lactation College, which is a unique lactation consultant training program for minority women. In 2016, she was named medical director of breastfeeding medicine for the 6th Hospital St. John Providence Health System, and she serves as the medical director of Cofective. So we're very glad to have her. I wanted to let you know that if you have any questions, feel free to type them into the question box, and we will answer questions at the end. And this webinar provides CERPs and CEUs. And so without further ado, we will turn things over to Dr. Paula Schreck.
Thank you, Margie, for that great introduction. I am Dr. Paula Schreck. I am a pediatrician and a lactation consultant, and I am honored to be here on this webinar that serves my beloved Midwest region, but also the whole country as well. Your program is very impressive. And I believe that if given the right support, most women can succeed at breastfeeding. I believe that providers are key to this success, and that's why I'm here. And by the end of this module, I hope that you too will share this belief. And so today I am going to focus on providers, engaging providers in breastfeeding promotion, particularly in their office setting, but spanning into the hospital too. And I will focus on the pediatric side of providership, as that is my wheelhouse, as I am a pediatrician. So we'll be talking about that explicitly today. These are my disclosures. I am the breastfeeding coordinator for St. John Providence Health System, but I also have these roles. I am the medical director for Cofective, and the images and approach here today were developed within my role as the Cofective medical director, and I'm also the proud co-chair of the Michigan Breastfeeding Network in Michigan, and love work at the coalition level also, and Wayne County Breastfeeding Coalition. So this is Detroit, Michigan. Let's begin my story here on the shores of the Detroit River. Once a hub of manufacturing, Detroit survived a scandal, an exodus, a recession, and a bankruptcy. And we are now reinventing ourselves as a technology and food industry hub. And this is Detroit. The infant mortality rate for Detroit is 15 per 1,000 births, with African-American babies experiencing an infant mortality rate twice that of their white counterparts. For reference, the infant mortality rate for the state of Michigan is 7 per 1,000. So the infant mortality rate in Detroit is twice that of the state. Other health incomes in children in Detroit also exhibit a striking racial and economic disparity, including such entities as obesity, diabetes, asthma, and hypertension. And indeed, another disparity exists. The women of Detroit do not breastfeed at the same rate of their counterparts. Breastfeeding initiation in Detroit is almost 30% below the initiation rate in the rest of the state, and the exclusivity and continuity lag even farther behind. Let's zoom in on my home hospital for a little case study. This is St. John Hospital and Medical Center. On the easternmost border of the city of Detroit, our hospital helps to serve this diverse population. In 2004, we took a long, hard look at our breastfeeding services. The breastfeeding initiation rate at our institution was 55%, with a wide racial and socioeconomic disparity noted. And we responded by building up our inpatient lactation service from 2 lactation consultants to a total of 7 lactation consultants with 7-day-a-week coverage, night coverage. I became the medical director of the service to facilitate this growth. But still, we saw no increase in breastfeeding initiation rate. We were still stuck at 55%. So in 2008, we created the St. John Outpatient Breastfeeding Clinic to assist mothers with breastfeeding issues after discharge. The clinic, which is still active today, is a physician-led and problem-focused clinic. Our patient satisfaction is very, very high. However, it had no effect on breastfeeding initiation in our institution, and interestingly, there was no effect on breastfeeding continuation rates either. So the women that attended the breastfeeding clinic breastfed for no longer than those that did not. Given that this was a self-selected population of women that had problems, you could understand that. But my point is that the St. John Outpatient Breastfeeding Clinic, although a wonderful resource and useful tool, was not the savior of our breastfeeding outcomes. So in 2011, we took a more holistic approach and jumped onto the baby-friendly pathway. And baby-friendly really opened our eyes to a more proactive approach to breastfeeding promotion. Instead of being problem-focused like the breastfeeding clinic, we shifted our efforts to quality improvement, to education, and to community outreach. And we succeeded in our endeavors with St. John becoming the first baby-friendly hospital in the city of Detroit. And I'm quite proud of that. It's a rare gem in the world of baby-friendly, as most baby-friendly hospitals are not in urban areas, and most baby-friendly hospitals are not in areas that serve the African-American demographic. And baby-friendly worked, with breastfeeding initiation rising and racial and economic disparities narrowing. And the improvement in breastfeeding initiation was seen in our clinic population that serves our poor population, the Medicaid population, where you can see that our breastfeeding initiation rates, which were lower than the overall rate of 55%, which were in the mid-40s, rose to almost 70%, thus closing that racial, almost closing that racial and socioeconomic gap. We then accomplished baby-friendly accreditation in 3 other system hospitals within 2 years. So now that means that we have over 9,000 births and over 1,800 prenatal patients a year under our baby-friendly umbrella, spanning every demographic, every suburb, every corner of the Detroit metropolitan area. So as the physician lead for these baby-friendly initiatives at multiple hospitals, it was my job to educate all of the providers for my system, for my hospital, and this numbered in the hundreds. Often the provider groups could not be necessarily described as enthusiastic participants initially, but it was my job to educate them nonetheless. But soon I found that educating was not enough. Education works if your goal is to pass a test. And this is often the focus of provider education because we like tests. But education did not necessarily lead to the behavior change that I needed to see in order to get through a baby-friendly assessment and to fully implement these baby-friendly practices. And behavior change is what we needed. It was motivation that I had to foster to build a foundation for change, for culture change. So this is an image that I pulled off of Google, off the internet, when I Googled doctor lecture. This didactic format for most provider lectures works well for some topics, but it was not working well for me for an issue like breastfeeding, which has such heavy cultural, family, traditional, and economic overtones. So let's go down to the basics of any communication. When we are communicating or selling any product or initiative, we have to communicate three things. We have to communicate what we're doing, how we are doing it, and why we're doing it. And most of the time we start with the what, and then we proceed to how, and if we have time, we talk about why. And that's if we have time. But does that motivate people to buy what we're selling, to buy into what we're trying to promote? Well, a gentleman named Simon Sinek, a motivational speaker and marketing consultant, pioneered the concept of start with why. Now, I did not hear about this approach in medical school or at the latest academy meeting. It was my collaborative partner, Mr. Comfort, the founder and president of Coeffective, who was educated at a business school, not a medical school, that was a student of this concept and introduced me to the books. But this approach gave structure and meaning to my findings during my provider education experiences. I want to show you a few examples of this effect. Let's go first to the tech industry. So this is from a screenshot from the Dell Computer website. So on the first page, Dell Computer is careful to outline and to highlight what they do. Dell reduces deployment costs by making economical PCs. They also do outline how they do it. They do this by installing Pro Deploy Plus for clients. And where is the why on this website? Where is the why in Dell Computers? Well, I did find the why, but it was buried deep within the website. And the why was that Dell Computers does what they do because they believe better work begins with a better workspace. Now that's interesting, but it took me several minutes to find that. And only because I was motivated to try and find the why was it ever possible to see this part of their website. Now let's look at another popular IT company, Apple. Now Mr. Sinek uses Apple as an example of a company that leads with why. Our products will enhance your life, every moment of your life. You will be able to experience our genius and benefit from it. Oh, and by the way, we make cool computers. We don't need to tell you how we do it. We just do it. So you can see that this motivates you to think about buying into the concept of Apple without anything about what or how. Who do you know that's passionate about their Dell computer? But who do you know that's passionate about their Apple products? Well, I don't know many enthusiastic Dell users, but I know many enthusiastic Apple users, myself included. So the why approach fosters motivation and even passion. Let's go to our own industry, the health industry. And the health industry has started to engage in this practice. This is from a GlaxoSmithKline product. And GlaxoSmithKline is the largest pharmaceutical company, one of the largest, and it makes Nicoderm and Nicorette gum. In 2017, early this year, they took a different approach to the promotion of their smoking cessation products. Their main insight was that the target audience did not need to be educated any longer on the health risks associated with smoking. Instead, they needed to be inspired and motivated to proceed with basic tools that tell them how to do it. So they called it their What's Your Why campaign. And their What's Your Why campaign resulted in a 54% increase in fans for the Nicorette Facebook page, 107% increase for Nicorette and Nicoderm CQ combined Twitter following, and over 71,000 why stories from clients were shared from patients. So let's flash back 2010. This is Dr. Paula Schreck provider education at St. John Breastfeeding at the time. I led with what breastfeeding did for their patients, and these were some of my exact slides. So this is a what slide. This is more what. Lots of statistics and words, lots of education, lots of things that will help a provider pass a test if it's given afterward. And I did talk about how we were going to achieve these breastfeeding outcomes. I would list the baby-friendly 10 steps and go through them very systematically. Again, educating the physicians, the providers on the baby-friendly 10 steps so that they could pass a test on what which practices were covered in the 10 steps. But I had no why game at all. So let's breastfeeding education for providers when we apply the why principles. Let's flash forward Paula Schreck, Provider Education 2017. I like to think of breast milk as a drug, a life-saving drug that prevents infection and inoculates against cancer. The drug is free and does not require insurance, electricity, or running water. And what if I told you that drug was accessible to all, regardless of race, education, or zip code, and it was in your power to write a prescription for this drug for your patients? So why breastfeeding? Why are we here in this conversation about one of the most basic maternal and infant behaviors? Well, it's because breastfeeding rates are not what they should be, and this is affecting the health of our population, and it has been doing so for generations. It's helpful to understand the context around breastfeeding practices over the years that have contributed to our current approach to breastfeeding. And many of these practices are based on misinformation and perceptions that have now been proven to undermine breastfeeding success. Yet these practices continue to be perpetuated year after year, provider after provider, and office after office. So you can see that this approach, we are acknowledging that the modern physician knows that breast milk is superior in content and effect. But it's time to shift the discussion to process and practice instead of facts and figures. I also find it's helpful for providers to understand how current practices came to be standard practice. Sometimes we're doing something for so long as standard practice, we can't remember why we're doing it. So I like to go over the trends in breastfeeding so I can help them understand where we started, where we are now, and how we got there. So sometimes it's nice to start with a little historical perspective, and I have lots of luck talking to physician groups and leading with a historical perspective on breastfeeding. So we'll look at the trends in breastfeeding to understand where we are. And we point out that for thousands of years, breastfeeding was the cultural and social norm. Breastfeeding was a symbol of health and resilience, motherhood, and family harmony. And this was likely something like a Christmas card or something that was put on a wall. Now, can you imagine this as our Christmas card today? We also need to remember as providers that breastfeeding was practiced in every corner of the world by every culture, every race, every social class. It's not just for some populations. It was necessary for the survival of a population. But with the turn of the 20th century came the medicalization of birth and the move to the hospital, and hospital practices often made it difficult for those who did choose to breastfeed to be successful. The use of labor drugs, heavy sedation for vaginal births, lengthy hospital stays, and routine formula supplementation with strict scheduled feedings all had a negative impact on breastfeeding success, and providers were the driving force behind all of these changes. What about this image? Mandatory separation of babies and mothers for 12 to 24 hours was well-meaning, meant to protect the infant from infection, but that practice too undermined breastfeeding efforts. And it's also important for providers to understand the cultural context as well. Meanwhile, at the same time, African American cultures were still reeling from 300 years of the oppression of slavery, and many Black female slaves were forced to breastfeed white owners at the expense of their own. So even generations later, breastfeeding was viewed as a symbol of racism and loss. And these pictures are hard to look at, but they tell the story of generational cultural motivations and cultural biases that we might not be able to understand. And sometimes the watered down commercial images of our society can't tell that whole story, even when a message such as this, an African American woman feeding her infant a bottle, are very powerful. In the 1940s, forces of war and industrialization drove mothers into the workforce, as represented by the iconic Rosie the Riveter image here. Interestingly, the U.S. could make airplanes and tanks, but could not make a good breast pump at this time. So effective breast pumps were not available, and breastfeeding failure became more and more common, and working mothers began to embrace alternatives. At the same time, a profitable industry of processed food began to take hold, replacing our most basic natural foods with those created in factories. And with this environment, another industry began to flourish. The infant formula industry thrived during the processed food revolution because of advertisements such as these that effectively portrayed infant formula as superior in origin, taste, and nutrition. And in 1959, a novel marketing campaign provided infant formula to hospitals at low cost or no cost, using pediatricians' endorsements to promote formula as a preferred method of feeding. And this marketing practice continues today. Now, why do I talk about these historical forces when talking to providers? Because it frames the growth of the formula industry that pediatricians in particular are closely tied to financially and professionally. But it frames the growth of the formula industry as it happened, not necessarily as a medical industry, but as a food product. Again, this is about culture change, so helping the providers see the big picture, the whole story, really helps. So it's not surprising by 1972 that breastfeeding initiation rates in the U.S. dipped to an all-around low of 22%, with an entire generation of women who did not breastfeed at all and were unable to pass along any legacy of successful breastfeeding. So breastfeeding began to be viewed as a lifestyle choice, something practiced by the few women who had the time and money and image to support the practice. After the nadir of the early 1970s, breastfeeding rates rose thanks to grassroots and faith-based organizations such as the Leche League that brought breastfeeding back in the context of natural mothering. Rates took another dip in the late 1980s and early 1990s, attributed in part by many mothers returning to work. But in the last 20 years, the United States has enjoyed a steady improvement in breastfeeding rates with the continued peer-to-peer support from grassroots organizations and the emergence of organizations that address cultural nuances of breastfeeding, such as Black Mothers Breastfeeding Association in my own city, ROSE, and National Medical Association. So these types of discussions on data give providers some context to today's breastfeeding rates, but I really focus more on trends as opposed to actual rates. And I also like to show some images that indicate that we still haven't reached our breastfeeding goals, and both Indiana and Michigan are solidly in the category of not yet meeting our Healthy People 2020 goals on breastfeeding initiation. But don't doctors have to know the benefits of breastfeeding? Absolutely. But when I engage providers in the benefits discussion, I like to frame it to set the stage for an even bigger discussion. So yes, I talk about breastfeeding decreasing SIDS, pneumonia, and gastrointestinal illness, otitis media, and other common pediatric diseases. We do talk about the fact that breastfeeding is not just for the infant, but also for the benefit of the child, with a decrease in obesity, reactive airway disease, and atopic disease, an increase in IQ, and that the benefits cross over to the mother as well, to decrease breast cancer and cardiovascular disease. But my point is not to just list the benefits of breastfeeding, but to really hone in on the diseases that impact the providers the most. The evidence is clear that breast milk is the optimal first food for infants, with the potential for significant health impact for both mother and baby. So I don't have to convince them of that. But what I do have to convince them of is that breastfeeding is not a lifestyle choice, but a public health decision. And it should be promoted as enthusiastically as we promote other health initiatives that impact people's choices, such as vaccines, weight management, nutrition, and cancer prevention. So this, of all the slides that I show on provider education, is my most important message. Breastfeeding is not a lifestyle choice, but a public health decision. Most providers think that they are supporting breastfeeding, and in general, they are, but why are our breastfeeding outcomes still missing the mark? Our breastfeeding initiation rates are improving, but even if we give ourselves credit for that, our racial and economic disparities are unacceptable. Further, only 1 out of 5 women are breastfeeding long enough to meet our own Academy recommendations. For the pediatrics, that's breastfeeding until at least 1 year of age. For the World Health Organization, it's breastfeeding until 2 years of age and beyond. So it's time to transition from setting the stage to action. It's clear that breastfeeding outcomes will not improve without the participation of providers. And right now, it seems like providers are kind of on the sideline. So why providers? Well, numerous studies show that health providers have a strong impact on mothers' infant feeding decisions. When women receive positive support and encouragement from their providers, they are likely to breastfeed longer. Encouragement from pediatric providers is powerful. One large national study found that mothers who perceived that the pediatric provider was neutral or favored supplementation with formula had much lower breastfeeding rates. In contrast, women who perceived that their pediatric provider favored exclusive breastfeeding had 53% higher odds of exclusively breastfeeding at 1 and 3 months. So this answers the question, the comments that often providers say is that, especially pediatric providers, I don't have any power in this decision. I take care of the baby after the baby is born. This is not about me. Well, it actually is. Pediatric providers are very important in framing this decision and the breastfeeding success. Some providers may think I serve a poor population. This data does not really relate to my situation. On the contrary, provider actions are even more influential in the low-income populations. The National Women, Infants, and Children's Feeding Practices Study found that when WIC mothers received advice from their providers, they have more than 2 times the odds of initiating breastfeeding compared with those mothers who did not receive this advice. Interestingly, especially for those of us in the breastfeeding field, WIC mothers who report receiving advice to breastfeed from their provider also breastfed an average of 1.7 additional times a day. And those of us that are direct service providers for breastfeeding support know that this can have a significant impact on the success of breastfeeding and ultimate duration rates. So when promoting breastfeeding to the providers, I like to get inside of their head and really get in front of what they may be thinking. So I'll even say, you may be thinking, isn't it best to remain neutral so that women can make their own decisions? Well, actually, research shows women interpret a provider being neutral as being passive and thus non-supportive. And further, the no preference attitude by staff and providers is a significant risk factor for failure to breastfeed beyond 6 weeks. The provider may be thinking, I don't want to make mothers feel guilty if they're not going to breastfeed or if they want to supplement. Remember, the providers are the informers, the educators, the advisors. The mother is the decision maker. It's our job to inform all mothers on best practice. Mothers often make decisions to give formula based on long-standing cultural biases and lack of information. She can't make a good informed decision without all of the information. Pediatric providers should instead be worried about the guilt that mothers may feel when their breastfeeding fails due to lack of support. Education does not create guilt. It prevents regret. So there are 3 distinct windows when we as providers and staff can influence feeding decisions and breastfeeding outcomes. Now I'd like to look at these 3 windows from the pediatric perspective, so we can look and see the best way to promote breastfeeding in different settings where pediatricians live and work. Let's talk about the prenatal window first. We all know that the path to successful breastfeeding begins before delivery. It begins before the mother even becomes pregnant, with the shaping of her attitudes and perceptions about breastfeeding. So let's talk about the pediatric office. Does your office promote breastfeeding as the normal way to feed infants? Or does it instead, perhaps subtly, promote formula feeding through the presence of coupons, samples, and magazines? You may be thinking, we're a pediatric office. We care for babies once the decision is made. So I would like the pediatric providers to ask themselves, how many pregnant women were in your office today? Quite a few. Quite a few. Bringing in their other children, maybe for a prenatal visit, but we care for women and children of reproductive age. So there's lots of pregnant women in our offices, even though we're not doing the prenatal care. Remember that formula gift bags have been proven in the literature to discourage and undermine breastfeeding. Gift bags like this one are often marketed directly toward breastfeeding mothers in a specific attempt to undermine breastfeeding. Gift bags are against the World Health Organization Code of Marketing and are not allowed in baby-friendly hospitals. And likely, formula gift bags are not being given at your institution, with greater than 50 to 60% of the institutions in the United States now discontinuing the practice. But is your office giving out these formula gift bags, either postnatally or prenatally? If so, I urge you to consider to discontinue this practice. But you may ask, what about our formula feeding families? Don't worry, they are getting plenty of formula samples in the mail. They do not need samples from you. What about our families that are poor that need formula for their babies? Again, giving them 2 bottles of ready-to-feed formula or even 1 can of formula will not address their larger problem of food security. Instead, refer those families to the local food pantry, emergency service lines, or health departments for a sustainable stream of food for their infant. After you remove all of the formula advertising from your office environment, you should now have plenty of room to hang a breastfeeding poster. So we have so many images in our offices. I don't know about your office, but in my office, there's posters, tables, tents, brochures, handouts, signs. What are they promoting? They're promoting products, they're promoting medication, and some of them indeed are promoting infant formula and bottle feeding. Why not use the space to promote our miracle drug, breast milk? Well, you may say, not all my patients want to see pictures of breastfeeding. I got dads, I got grandmas, I have people that aren't breastfeeding. Exactly. The marginalization of breastfeeding is what has contributed to our formula feeding culture. Natural and culturally diverse images of babies being nurtured and fed are perfect for any waiting room or exam room, and they help to normalize breastfeeding no matter who's sitting in front of it. So we like to call hanging a poster one of our high impact behaviors. So what is a high impact behavior? It is an action that we have defined as one that is not only effective but also efficient in cost and in time. We understand that the motivations of the modern provider are to deliver quality, holistic care, but we also understand that any additional steps added to the complex routine of this office, which is already navigating EMR, quality measures, meaningful use, and other initiatives, must be efficient. So we have identified 4 high-impact behaviors specifically for providers. Hanging a poster is the first. It's easy, it's cheap, and you can do it today. We'll discuss others throughout this hour. So high impact behaviors is based on another behavioral theory that we have used through our approach called the Fogg behavioral theory. Mr. Fogg's equation is behavior equals motivation times ability times trigger. So that to accomplish a very difficult task, you must have very high motivation, but easy tasks require less motivation and effort to achieve behavioral change. So sometimes providers will reject breastfeeding initiatives or breastfeeding promotion or even baby friendly because it's a hard thing to do, and it is hard. So if we can identify easy, immediate actions, high impact actions that providers can start today and tomorrow, they will be more willing to get into the game. So even though we're talking about a breastfeeding-friendly office, I do want to transition to a brief discussion of the evidence-based practices that support breastfeeding at the hospital level. Educating mothers may be effective in encouraging mothers to consider breastfeeding, but it does not guarantee breastfeeding success. To empower mothers to be truly successful, we must contribute to the hospital environment that supports breastfeeding by the provision of evidence-based care. And in all of the educational programs that I write, I use the gold standard for evidence-based maternity care as the Baby-Friendly Hospital Initiative. Over 1/3 of the hospitals in the United States are either baby-friendly or working toward designation. But even when I'm talking to provider institutions that are not seeking baby-friendly, an understanding of the key core practices is key to holistic and effective approach at breastfeeding promotion. In my own home state, the baby-friendly movement is very active. Michigan currently has 12 baby-friendly hospitals with many more on the pathway. Michigan was heavily represented in the National Baby-Friendly Initiative's Best Bud Beginnings and Empower. And we now have a pure Michigan baby-friendly collaborative called the QI Jumpstart, which Margie and I lead, a group of 10 hospitals of diverse size from all parts of the state that are moving through a 1-year curriculum that is moving us closer to baby-friendly designation at those institutions. And I like the providers to understand that these initiatives, this initiative, Baby Friendly, combines breastfeeding promotion with education, quality improvement, and community outreach. And it's for all babies, regardless of feeding choice. Pediatricians should have a basic understanding of hospital practices and their nuances because women will ask us about these practices before they deliver, and that these practices apply to all newborns. Such as skin to skin for the baby who is going to be formula fed. Nuances like the fact that skin to skin should be uninterrupted for 60 minutes. And that skin to skin can occur even in the operating room. Pediatricians need to understand that assistance with breastfeeding has to be a deep bench, that it can't just be the one lactation consultant on the floor, but nurses and providers have to be proficient at assistance with breastfeeding. And that there's not just a benefits discussion that needs to occur, but a risk discussion that needs to occur about the risk of supplementation. I like to frame again the fact that most pediatricians know about the benefits of rooming in, but do they know that really to have full benefit of rooming in, one has to have all procedures in the room, with the exception of major procedures like circumcision, including the pediatrician's exam. This is a very hot button issue for many pediatric practices in the hospital, so I really like to reinforce that when talking to pediatric providers, even when you're talking to them in an outpatient setting. because you want them to model that behavior when they're inpatient. We also talk about the culture change from feeding every 3 hours to feeding on cue, and the avoidance of pacifiers in the first 4 weeks. So I go through all of these practices for the pediatric provider to really reinforce that, yes, there are a lot of moving pieces, but baby-friendly in itself is a high-impact behavior. It's effective and efficient. There are 10 steps, but if we were to undergo a baby-friendly transformation in an institution and do one project at a time, there would be 81 quality improvement projects to accomplish, and it would take us 10 to 15 years. But when baby-friendly evidence-based practices are implemented synergistically and simultaneously using the quality improvement construct of baby-friendly, it usually takes only 2 to 3 years to achieve baby-friendly designation. So that is much more efficient. So I really like to empower the pediatric providers to really own the postnatal window of feeding support. So instead of assuming that a mother is not breastfeeding, or that mother is having breastfeeding problems, we train providers to ask open-ended questions. How is breastfeeding going? And affirming the importance of breastfeeding. And this is a very important high-impact behavior. We're so used to checking the box. Are you formula feeding or are you breastfeeding? Or how are you feeding the baby? And once the answer is given, we check the box and move on. Instead, affirm the importance of breastfeeding. As your provider, I support breastfeeding. As your provider, I prefer breastfeeding, just as I prefer you to get your vaccines. Now, what if you don't prefer breastfeeding? What if your personal experience is such that you have children that weren't breastfed and they're healthy, or you yourself had a bad experience? Then rely on science. Blame it on science. As your provider, I've reviewed the evidence, and the scientific evidence is clear that breastfeeding is the preferred choice for infants. You can take it out of the personal affirmation if you're not comfortable with that, but putting it forward as the preferred feeding choice is easy, it's efficient, it takes a couple seconds, and it's extremely powerful. Refer to community resources. Breastfeeding education, especially if we're including education on evidence-based practices in the hospital and mechanics and logistics of breastfeeding, is a daunting task for a pediatrician who has 10 to 15 minutes per patient or less. The community is there. The community is willing to help with the education of breastfeeding, of your patients about breastfeeding. And they're also more suited to address other social determinants of health, like food security, housing security, shelter. So referring to community resources, knowing your community resources, and doing meaningful handouts to those community resources is a high impact behavior for providers. Referring all patients, irregardless of race or your perception of what their income is, because it's been proven in the state of Michigan with some studies that we've done that most providers and most staff nurses grossly underestimate the income requirement for WIC. And therefore, many patients are left without a referral who could have benefited from one. And our final high impact behavior is modeling best practice. I like to empower the provider to be the clinical leader of the team in the hospital and the office, and that the staff watch them and what they do. If they have a pro-breastfeeding attitude, if they have pro-breastfeeding affirmatory statements, it will catch on, especially in a small space like an office, and even in the hospital as well. I encourage providers that day to try doing a pediatric exam in the room when they round. The nurses will notice the change in practice and will appreciate that, and that will carry over into their own practice. I am very proud of the health department in Michigan's commitment to breastfeeding promotion and the support of breastfeeding programs in our state, working very closely with them at both the state and local level. An example of how we're using this approach to provider education can be found in the city of Flint, which recently survived an environmental disaster. The Michigan Breastfeeding Network and the Michigan Department of Health and Human Services is launching a Why Breastfeeding Office Edition campaign in the city of Flint. We're going out to multiple doctors' offices in the state and in a lunch and learn format, educating providers by motivating and drawing them into the promotion of breastfeeding as a public health initiative. A lot of these slides are from that presentation that we developed. The Why Breastfeeding Office Edition is also being promoted across the entire state in the state of Louisiana through their health department's program called The Gift. Both of these programs tie into a consistent message. Consistent breastfeeding promotion education that crosses out of the genre of handout and onto phones and iPads, and includes in both states a comprehensive resource profile or guide so that it helps providers practice that high impact behavior of referring patients to local breastfeeding support. And this is the Cofective system. This is a picture of a screenshot of the Cofective resource platform. And we're also passionate about consistent message. So the provider education, the staff education, and the patient education speaks the same language. And this too is a high impact behavior, because when we're all saying the right things, but we say it differently, we may be perceived as wrong, inconsistent. But if we're all speaking the same language and the mothers are seeing the materials in multiple different locations, suddenly this is a message. This is something to pay attention to. And it is then that we start to see the effects with increase in breastfeeding outcomes. So I hope you can see that we use motivation and behavioral theory to really engage the provider in starting with breastfeeding promotion right now. But what about breastfeeding management? Well, breastfeeding management is very difficult. And so what we like to do with the first time that we're in the provider office is not just give a list of resources and not try and dictate the breastfeeding management of different problems like this horrific latch here in this picture, but instead we empower them to learn more. So in the Why Breastfeeding Office Edition, we're actually in the doctor's office for an hour without a lot of discussion on management of breastfeeding. But we do discuss hot button issues like poor latch and the management, the awareness of weight gain issues and where to find resources to help them manage their patients with these issues. And I like to remind providers of the power of expressed milk, that when babies require supplementation, that doesn't necessarily mean formula, but expressed milk from mother's breast, or in some cases when available, donor milk, can definitely be used in lieu of formula for supplementation. But there is one topic that I like to really hit home in both pediatric and obstetric offices, and that's the topic of medications and breastfeeding, because of all the calls that we get in our offices regarding breastfeeding problems and issues, the interactions with medications is perhaps one of our most common calls. So we like to have providers understand that most medications are safe for breastfeeding, including very popular postpartum medications such as antidepressants, antibiotics, steroids, asthma medications, and contraceptives. And we really want providers to know where to go for appropriate lactopharmacology, referring them to Thomas Hale's iconic text or to LactMed. So that they too can be perceived as a breastfeeding friendly office. And from our discussion, we now know that perception is everything. And when mothers perceive that they are part of a breastfeeding friendly office, things will go better. I definitely like to call out the Academy of Breastfeeding Medicine protocols and other references to providers. Nowadays, it's less important to convey all of the facts and figures to providers in a lecture, as long as you give them references. So a good list of references is a very nice handout to engage a provider's office, giving them some direction as to where to go for information if they're having difficulty with management or have questions. So I would like to leave plenty of time for questions at the end. So I'm going to start to wrap up this discussion today on why breastfeeding for pediatric providers. I'd like to thank you for joining me and hope that we can take these lessons that we've gone through today and create a new culture, a culture of the breastfeeding friendly provider, culture of breastfeeding friendly pediatric offices. Thank you very much. I now have 5 minutes for questions.
Great. Thank you so much, Dr. Schreck. Everyone, if you would like to ask a question, you can type it into the question box that you should see on your taskbar. And I did have a question that was emailed to me, and the question was, Dr. Schreck, do you have any suggestions for setting up an LC in a physician's office?
Yes, I do. As you know, there are multiple barriers to reimbursement by lactation for the care provided by lactation consultants. But with the Affordable Care Act, which is still the law of the land at this moment, there were some openings to that real difficult barrier. In addition, ICD-10 provided some additional ways to accommodate lactation consultant care in the office. For ICD-10, there were two codes, 94115 and 94116, which pay for the extension of care. So if the provider, a pediatric provider, is in a room with a newborn for 20 minutes, they bill their procedure code for their 20-minute face-to-face time. But if a lactation consultant or it doesn't even have to be a lactation consultant, it can be any healthcare provider, goes in, any direct service provider, it could be a peer counselor also. Any staff from the doctor's office goes in after the provider to give support. Those extension codes can be applied for up to an hour after the provider leaves the room, and does lead to some reimbursement to the range of $40 to $60. Under the Affordable Care Act, there was the requirement that insurance companies pay for lactation consultant visits. However, the logistics of that have been proven to be difficult. There are some codes, S9443, which is a breastfeeding class code, which can be used for by a lactation consultant. In the state of Michigan, it has to be an RN IBCLC, and this can be fired on a encounter form on the same day that the provider sees the patient. So those are two ways that lactation consultants can be incorporated into the pediatric office.
Great, thank you. Somebody had asked if it was a possibility to watch this presentation later. And yes, all of the Indiana Perinatal Network webinars are archived. You can find them by just Googling Indiana Perinatal Network webinars, and you will see all of the webinars there archived. Give us about a week to get this webinar up and loaded and available to be viewed. I wanted to let you know also that we were having some technical difficulties sending out SERPs for the previous webinars, so we will be sending those out. Again, we were just finding that even though we sent them, some people weren't getting them, so we are going to be resending those. And then to encourage everybody to mark their calendars now for the next webinar, which will be Tuesday, April 18th from 1 o'clock to 2 o'clock. And we will be talking about public breastfeeding laws. And it's actually going to be another great collaboration. And this time we're adding in another Midwest state. We're going to loop Ohio in. So along with Michigan, we'll have Shannon McKinney-Schubert from Michigan. And she is passionate about improving the health of women and their families. And she's going to be talking about our Michigan campaign in order to normalize breastfeeding in public. And then Lori Nestor from Ohio is going to be discussing 2 projects that the Ohio Breastfeeding Alliance has been working on to support breastfeeding in public. So we're excited to hear both of them next month. And I think that might be it for questions, unless I'm just not seeing them here. And again, we'd like to say a big thank you to Dr. Schreck for sharing her time, knowledge, and just the great resources that she is to the state of Michigan and now really to Indiana also. So thank you everybody for joining us, and have a great day.